Assalamu alaikum. In 10 clinical minutes, we will be discussing treatment options for Pyoderma gangrenosum. Pyoderma gangrenosum is a reactive inflammatory, neutrophilic, and recalcitrant dermatosis, characterized by painful and aseptic ulcers. Clinically, it usually starts with a small pustule or papule that develops into a painful, irregular ulcer with undermined edges with a reddish-violet color around the edge. It is commonly found on the lower limbs. However, any other part of the body can be affected. Classically, there are 5 types of Pyoderma gangrenosa: the classic type or the ulcerative, the pustular, the bullous, peristomal, and finally superficial or vegetative granulomatous type. Pyoderma gangrenosa is known to be associated with several disorders, most commonly inflammatory bowel disease. However, it can occur also in several inflammatory arthritis, like rheumatoid arthritis. It can occur with hematologic abnormalities, malignancies, and finally, the Papa syndrome and its spectrum. Pyoderma gangrenosa can be misdiagnosed because there are several mimics of Pyoderma gangrenosum. The most difficult to differentiate would be vascular disorders, including vasculitic disorders like polyarthritis nodosa or vascular flow abnormalities like stasis and ischemic ulcers. Neoplasias also may mimic Pyoderma gangrenosa, for example, a very large basal cell carcinoma. Infections like eczema gangrenosa, iatrogenic causes of Pyoderma gangrenosa may include treatment with granulocyte macrophage colony-stimulating factors, and also cocaine abuse may result in Pyoderma gangrenosa-like lesions. There are other miscellaneous mimickers of Pyoderma gangrenosa. The most famous is the extracutaneous manifestations of Crohn's disease and self-inflicted or dermatitis artifacta. The pathogenesis of Pyoderma gangrenosum depends on having a genetic defect and an immune defect, resulting in severe immune dysregulation with the development of the Pyoderma gangrenosum lesion. In the genetic defect, there is an hyper-excitable immune response, primarily of the innate immune system. We think that the disease begins around the hair follicles, and there are several theories of the precipitating factor, including trauma, drugs, and the associated disorders which we just mentioned. These precipitating factors will stimulate an already hyper-excitable immune response, and this will lead to upregulation of several cell lines and pathways. There is upregulation in the inflammasome pathways. T helper 17 cells and T helper 1 cells are abundant in the Pyoderma gangrenosum lesion, and there is also some studies discussing the role of T helper 2 cells. All this will create a melee of cytokines and chemokines and complement factors. This will lead to recruitment and proliferation of the neutrophils at the site of the Pyoderma gangrenosum, with the formation of the neutrophilic extracellular traps, leading to severe tissue damage and the ulceration. The nets with the neutrophils will also secrete matrix metalloproteinase 9, which may further widen the ulcer in the affected area. So what is our treatment options for Pyoderma gangrenosum? First of all, we should do proper wound care. Medications may include topical treatments, but they are mostly adjuvants to systemic therapy. The best evidence for topical therapy exists for corticosteroids, whether potent or super potent topical steroids, followed by calcineurin inhibitors. There are some trials for the use of timolol maleate drops, which may help reepithelialization. Other drugs that had been tried in the topical treatment of Pyoderma gangrenosa include phenytoin and sodium chromoglycate. In almost all patients, we may have to use systemic therapy. Our first-line systemic therapy for Pyoderma gangrenosum include corticosteroids and cyclosporin. We can give corticosteroid as monotherapy or cyclosporin as monotherapy, or combine both medications. Our second line includes mycophenolate mofetil, but it's always an adjuvant to corticosteroids if first line failed, intravenous immunoglobulins, and dapsone, which are all adjuvants in the treatment of Pyoderma gangrenosum. Some other drugs have been tried in Pyoderma gangrenosa, but there is limited evidence about their efficacy, including methotrexate, azathioprine, thalidomide, minocycline, and colchicine. We now have high level of evidence regarding the use of tumor necrosis factor inhibitors in the treatment of Pyoderma gangrenosum. These drugs improve Pyoderma gangrenosum. For example, adalimumab, after using it for 1 year in patients suffering from Pyoderma gangrenosum, more than 50% of patients reached a PGA score of 0 to 1. And there was more than 60% reduction in pain. However, when the treatment is stopped, many patients develop a flare or recurrence of the Pyoderma gangrenosum. It's also worth mentioning that most cases and case series reported about the use of TNF inhibitors in Pyoderma gangrenosum were in patients suffering from inflammatory bowel disease. Paradoxically, there are many reports about TNF inhibitors actually inducing Pyoderma gangrenosum. Other biologics with moderate level of evidence include interleukin-1 beta inhibitors, where the canakinumab was actually better than the anakinra in such cases. IL-17 inhibitors, which also paradoxically may induce Pyoderma gangrenosum in some reports. We also have the complement 5A inhibitor, which showed good results in some cases of Pyoderma gangrenosum, and to a lesser extent, the IL-23 inhibitors have shown some response in patients with Pyoderma gangrenosum, but with less number of patients. We have limited evidence about some other drugs, including the 3 biologics IL-6 inhibitors, the integrin inhibitor, and the CD20 inhibitor rituximab. However, these 3 drugs, in some cases, have shown paradoxical development of Pyoderma gangrenosum. CD3I inhibitor have been tried with some success, and there is an ongoing trial now for the use of the IL-36 inhibitor, sphisulimab, in the treatment of Pyoderma gangrenosum. Other small molecules like the phosphodiesterase 4 inhibitor apremilast was used as an adjuvant therapy in some cases Pyoderma gangrenosum with promising results, and the same for the JAK inhibitors, which also seem to be effective in Pyoderma gangrenosum. Finally, there is the granulocyte and monocyte adsorption apheresis, and this technique reduces white blood cells, and it can be used as an adjuvant to the classic treatment or the other systemic treatments, or as a monotherapy. So how can we proceed in a case of Pyoderma gangrenosum? For all patients, we may want to use topical medications and proper wound care. And then we may decide our first line of treatment. It can be systemic corticosteroids, it can be cyclosporin, and it can be a combination of both. If I choose to use systemic corticosteroids and I don't get the desired response, I can add the second line treatment as adjuvants, including the mycophenolate mofetil, the dapsone, or the IVIG. The same if I've chosen cyclosporin as my monotherapy or first-line therapy. However, please notice that cyclosporin will decrease the effect of mycophenolate mofetil and will increase the toxicity of dapsone. If this still fails, I may add other adjuvants that I have discussed, which have limited evidence or less clinical trials, including the methotrexate and the azathioprine if I'm using systemic corticosteroids. If I'm using cyclosporin, I may use thalidomide or minocycline because the rest of the drugs that I have mentioned earlier may interact with cyclosporin, or there is not enough studies for the combination of cyclosporin with other drugs like, for example, azathioprine. I may also choose to start with tumor necrosis factor inhibitors as my first-line therapy, either alone or in combination with corticosteroids or methotrexate. Other combinations with tumor necrosis factor inhibitor are not mentioned clearly in the literature and have limited data. If all this fail, I may go to other drugs that I have mentioned also, like the interleukin-1 beta inhibitors or IL-17 inhibitors, or even the complement 5A inhibitors. And these also may be used in conjunction with corticosteroids or methotrexate. Finally, if everything else fails, I may try other experimental therapies, either alone or in combination with my first-line treatments. Thank you very much.